welcome Mr. Her full name is Don Lachai Hwangchu. Usually we call Ajan Don. Oh, you have a nickname?
Don.
Ajan Don?
Yes. Thank you.
Pidon. Usually I call the Pidon. Currently, Ajan Don Lachai is a lecturer from Department of Community Health from Faculty of Public Health, Mahidol University from Thailand. So he has many experience related to this topic. It's IV about the drug user. He has many experience about this topic. So this morning, I would like to invite Ajahn Don to give his lecture, and then we have student from the Department of Biostatistics and Population Study in Faculty of Public Health, Diponegoro University. Besides the student that come to this lecture, we also have Ajan Imaniar. Good morning, Ajan Imaniar. And also we have Ajan Dion. He will join soon. But I believe that this lecture will be very interesting because we would like to know how Thailand have the experience to overcome the HIV. Okay, please welcome Ajan Don. Time is yours.
Okay,
Yes,
thank
Ajan.
you. Selamat pagi. Good morning,
Selamat pagi.
everyone. Yes, I can remember a little some words. I and Tifali study together in a couple years. Okay. And this is my honor to become a guest lecturer for this topic. I try to share my work experience and academics perspective towards this topic because before I joined the faculty of Public Health Mahidol University, I worked in the non-government organizations for HIV/AIDS prevention under several international donors such as Global Fund, UNAID, USAID, and some local funding, mainly about the HIV prevention and my specialty in the area of drug use and migrant workers. And before we start, maybe I want to hear from all of you about the opinion or whenever you heard about, okay, I have an interactive game for you here. Just use your mobile phone and scan what you think about HIV when you hear it. Okay, waiting for the response.
Oke. Adik-adik silakan di-scan, kemudian Anda respon.
5, 6 response.
Okay, please use your mobile phone to scan the QR code.
Infectious disease. Oh, academic answer.
Gini,
Virus.
virus.
Maybe the answer is on the way on the way come here to Bangkok, Thailand.
So you need to wait a little bit.
Yes, it's quite different when I play it in my campus. It's online.
Directly, yeah.
Yeah, directly, instantly appear.
Standard yeah.
Wow, scary.
Scary.
Something frightening. Reproductive problems. Hmm. Oh, good. Immune system. Stigma. Good, good. The size of the answer is reflect to the frequency of answer. Mhm. HPV, yes. Discrimination, stigma. Mm. Hidden danger. Good. Waiting for the other students' answer.
Yeah.
Vaccine.
Let's
Uh,
see.
right now. Okay. 19 student answer. 19 of 28 respond. Okay. This is an alternative way for check-in.
Yeah.
Instead of use the name list and check who already come or join, I use this.
I see.
Wow, wow, good, good. Iceberg phenomena. Good. Deadly. Wow. Sigma. Okay, waiting for 5 more. Okay, maybe I try to sum up at this point. Mostly your student think about virus in terms of epidemiology, right? Scary. This is a kind of social aspect. Infectious, sure. Stigma, immune system. Another, are there any interesting answer? Sexual intercourse. Okay, empathy in terms of care and treatment, I think. So this can reflect that HIV not just only the medical concern, is also about the social, say, social aspect and social problem, right? That touch the feeling, emotions of people who might know or may not know about it clearly. 27 out of 33 respond. Okay, wait a few minutes. Vaccine here right now in the world, we don't have vaccine for HIV prevention. We don't have the vaccine yet. Maybe that might be reflect your hope for vaccine to prevent HIV. Mhm. Okay. Awareness. Not all people understand. Good. Even in Thailand, HIV spread throughout the country since 1984. How many years passed? Maybe 40 years, right? 44. Yeah. Almost almost half century. But people still fear and don't understand. Not all people understand about it. Mm. The situations similar to what you are answering, the same. Wow, vigilance. Mm. Health list, health at least. Okay. Judgmental treatment. Mm. Like a health provider maybe limit the choice of the HIV patients, right? Hidden danger. Good. Long term, maybe mean long term care or chronic disease, maybe. Prevention. Wow. Okay, maybe I can get the idea of your student. How do you feel and do you think about HIV when you heard it? Mostly about prevention, virus, prevention awareness, stigma, scary, and infections. Vigilance, that means you have to concern, right? Concern about it. Mhm. Okay, I think that you stop now for this uh ice breaking. Okay, let's get back to the content that I will share with you. Okay. Excuse me. Uh, can you, Faris, can you see the full screen? Okay, full screen, right? Okay. The objective of this class, I try to touch upon these following five topics to explain the relationship about HIV and reproductive health. Second one is to identify vulnerable populations that increase the risk of HIV and poor reproductive health outcome. The
Idon,
third,
sorry to interrupt.
yes.
I see not your full screen. I see
Ah,
the second screen.
okay, okay. Good, good. Stop first and
Before is full screen before.
okay.
Full screen now.
Now
Okay.
full screen.
Yeah. Thank you.
Okay, thanks to remind me. And then I try to describe the role of public health system in prevention, treatment, and health promotions. That's touch upon the public health, right? And following by the analyze the Thailand response to HIV and reproductive health challenge. How do we do in the past, past 40 or almost 50 years ago? And propose evidence-based intervention for vulnerable populations. And as I use the Mentimeter to get your idea, your answer is quite related to these key issue that I will describe and share the experience. HIV/AIDS is not just medical concern, it's also touch upon the right and healthy equity and social determinant of health. I think you are students may familiar with these words, social determinant of health, that's touch upon several factors in your society, government, management, and policy in the local context, and also related to the medicals and like health security in your country. In Thailand, we have universal health coverage or USC. I think you may familiar or have heard about this. That means everyone who was born in Thailand has Thai citizenship. We get these health security coverage to get free treatment for most of illness and disease. Mhm. Here, because HIV is a global situation, global epidemic, right? I try to recap the situation in the global precisely. That there are many patients, many cases living with HIV, and epidemic still concentrating on key populations and their partner. I will explain later what is the key populations. And also concern about reproductive health challenge, high rate of unintended pregnancy, sexually transmitted infections, and gender-based violence related to different from gender, and also limited adolescents access to social reproductive health services. For my countries, we mainly get funding support from the UNAIDS and Global Fund, and in the last mile I because ending AIDS. Have you heard about this? Ending AIDS by 2030. This year is 2026, right? 4 years left. That international support, the Global Fund or UNAIDS will stop funding support to all countries that receive funding from them right now. That means we have 4 years left. Uh-huh. And in the past, we success on universal ART for to prevention of mother to child transmissions. And however, the epidemics remained concentrated in marginalized and key populations. That global situation and Thailand context are quite similar. Here is the previous and most recent our program's performance. The PMTCT prevention transmission from mother to their children dramatically dropped from the very beginning when HIV come to Thailand from 20 to 40% drop to about 1.6%. And the coverage increased almost 100%. That mean mother who bearing their child and bearing their child can get access to prevention HIV transmission to their children. And this is we get how to say WHO use Thailand as a case study, the first country that certified to provide PMTCT. And what about the other performance? Previously, as you see, the 95, 95, 95, that means HIV care and treatment cascade. 95, that means we try to achieve 95% of people to get diagnosed and know their status. And for those who diagnosed for the HIV infections, we try to convince, we try to support them to get treatment receiving drug or ART at the same day or within 7 days to suppress their their virus. And the next 95, we aim to suppress their viral loads that below the level of transmission below of 200 ml. I can't remember about the denominator, but try to suppress the viral loads below the transmission. And for the below one is the outreach work that the key population that I mentioned previously. Key population is men who have sex with men, transgender people, male and female sex worker, and people who use drug. Even we have some number, we have population size estimation to estimate how many population, how many of key affected population in the country, but we cannot achieve everyone. Here is the past historical epidemic, how Thailand's impact by the HIV. In the first case detected in Thailand in 1984, when the tourists come back from the Western country, they get infections, HIV from the same-sex intercourse. That is in the past. There is some discrimination words for the HIV as the gay cancer. Have you heard about it before? Gay cancer. Never heard before. And when the first case detected in Thailand, and about 4 years or 3 or 4 years later, the situation, the epidemic concentrating on people who use drug, intravenous drug user that they share needle and saline injecting equipment widespread to people who inject drug. And the peak, the highest infectious disease infection rate increased among sex worker, female sex worker for 44%. That means almost half of people get infection. They are female sex worker. That's why in the past, these job or these populations were stigma and discriminate, and AIDS was called sex worker disease in the past. These are a form of discrimination, stigma, sex worker disease. Oh, and later on is passed through the general population from male client. The male who visits sex worker, they spread the virus through their couple, through their wife, and transmit to their children also. This is the long story in the past of Thailand that I try to shorten in single infographic. And next, historical HIV/AIDS response. This is how do we respond for the epidemic in the past. At that time, we used the concept like similar to framework, compared to cylinder is small cup. We should emphasize on prevention first. Prevention in this term mean HIV education and promote condom use. For those who infected already, we try to encourage them to entering to care for the routine HIV and HIV and STI testing, and to get treatment for ART. However, in the past, we use the fear approach or fear campaign is equal to death. We use the media or broadcast televisions to show people how what is their appearance, how do they look like when they get HIV in the last stage of their life. This is called fear approach in the past. Okay, that is a long history that I try to shorten in a couple slides, and how it's related to reproductive health, right? Because the topic of today is how HIV related and linked to sexual reproductive health. Some people may doubt, oh, this HIV impact on fertility rate in Thailand or not. I collect the data publications from qualitative and quantitative. This is some the results. The substantial epidemic burden that stigma construct. The stigma cause the reproductive health and fertility rate not directly to people who get HIV, but is related to internalized stigma, like for people or for women who get HIV, they less likely or not confident to bearing their child their children. Even we have medicine or ARV to prevent transmitted disease from mother to children, and they also fear about the a health provider to force them not having sex, not having family, or not bearing their children, or get pregnant. This is just small number of respondents, about 10 women from the qualitative study. It's not directly lower than uh, total fertility, but is indirectly to the stigma from both inside them and from the community they are living with. However, we don't have the nationwide demographic impact, how the HIV reduce the total fertility rate or not. If you want to conduct, maybe if you want to conduct study. Okay, here is some highlight the success story of HIV prevention in Thailand. First, we use 100% condom promotion programs and integrations of universal health coverage for those who want to receive HIV services. They get it for free. And here, as I mentioned quite often, to eliminate mother-to-child transmissions. And the next challenge by 2030, Thailand try to reduce new cases below thousands, but new cases still quite high. And 90% to reduce HIV-related stigma and discrimination in the country report. We achieved just only 30%. That means two-thirds left two-thirds of people still fear and don't understand and discriminate people who living with HIV or some key populations. This is the current gap, the high burden remaining in the key populations. Inconsistent availability of youth-friendly reproductive service. Even we try to promote the clinics, special clinic or special programs for youth in the hospital or in the school, but is also increase increase the intentions of people around surrounding them, and that clients may be related to unsafe sex or get infectious HIV infections already. This is has pro and con. Okay, and also HIV stigma in healthcare settings still exists. Even they have to provide care and treatment, but the the idea, the opinion towards HIV patients still in negative. Here is the summarize of Thailand 100% condom programs. We have universal mandate to say that no condom, no sex. These programs directly go to females, sex worker or sex establishment like nightclub, bar, massage, to start this program first. Because as the evidence I show you already, the peak time, the highest percentage of infections concentrating on female sex worker in the past, right? That is use the data targeting the target population and intervention, tailored interventions. After we promote 100% condom programs, wow, it spike up from 40% to more than 90% of condom use, because we promote and distribute it for free of charge at the time. And it's decreased HIV case more than 95%. Wow. Okay. Here is some information about the effectiveness of 100% of condom programs. It can reduce annual STIs and HIV case. This is one mechanism that I want to share with you. In Thailand, we have volunteer health, villager health volunteers. Mm. Usually, this group of people, they have to focus on the general disease and NCD. But whenever the HIV epidemic attack Thailand, they have to respond to this as well. However, they didn't train specialized train for the HIV care and treatments or response or case management. Then the knowledge and gap still exist among this group of people, and because they're living in the community close to the HIV patients, sometimes the HIV patients feel hesitate to review their status because they're living together in the same community. Sometimes the patients don't want to review their status. So these mechanisms still cannot confirm the successfulness of prevention, care, and treatment, but because their role and duty focus on general health education, risk screening of other infectious disease like flu or diarrhea or NCD. Even in the past history, we achieved many programs to prevent HIV. For example, condom program, universal ART access, prevention of mother to child, and universal health coverage. However, the situation at present, we still have a high burden among key populations and rising SIV incident among young people and sexual violence, and some youth-friendly services are still limited. I have some example. At present, maybe in the past, for people who can get HIV testing, they have to have at least 18 years old, for more adult, for those who have ID card. But at present, we unlock that limitation for everyone. Youth under 18 years can get HIV testing. However, in some cases, after they get HIV infectious disease, the condition to get the ARV, the medicine, they have to bring their family, their parents together. This is like how say contrasting. Even policies support them to get their status earlier at the younger age, but whenever they get diseases, they have to bring their parents to know their status. Okay, as I mentioned previously, what is the key affected population, right? Key population. We have many technical terms to use these kind of populations. In the past, we call them the marginalized population. Right now, we call them key population, key affected population, right? The concept, the situations, the disease concentrating among these group of people. You can see there's approximately 7 group of people. Men who have sex with men, transgender people, sex worker, both male and female. Right now, female sex worker not limit only female as in the past, male also. People who inject drugs, migrant worker, ethnic minority groups, adolescents and youth. Why do they vulnerable? Because it's driven by stigma, right? Being MSM, transgender sex worker, may be very, how say, unacceptable in Indonesia, like Muslim country, unacceptable, right? MSM, transgender. Mhm. But becoming sex worker in the Western country, that is a job, legal job, that's acceptable. But most of the country around the world, being sex worker is unacceptable, including in Thailand. Mhm. Ethnic minority group, people who live in the border area also cannot get respectations compared to local people. Mm. This is the different form of discrimination, limit access to healthcare. This is not their how say distinct characteristic like gender, biological factor. This is a social factor, make them vulnerable. Here is I break down to the 4 components related to the social determinant influencing HIV and social reproductive health. Structural factor like a poverty, wealth disparity. The poor cannot afford good food or cannot pay the medicine by themselves, right? Education gap. Lower education may not have the knowledge on HIV. That is an assumption. But right now, it's not about the knowledge. It's about behavior. Mhm. And criminalizations policy affecting marginal behavior, like commercial sex worker is unacceptable, right? So when they get infection, they don't have health security to get treatment. They have to pay out of their pocket money. This is you can read later. Here is infographic to reflect how the social determinants related to HIV and sexual reproductive health inequality. In the center, one is individual factor, right? When people have to face stigma and discriminations from people surrounding them, from their community, limited service access. In some hospital, the clinic not open 24 hours, 7 days. Some hospital once a month. Or operate in the government's office hour, open from 9:30 to 4:30 and close. Health systems failure, like in Thailand, people who register for the Universal Health Coverage Scheme have to get the drug ARV treatments in their registered hospital. However, can you imagine if I live in my community and the nearest hospital? I know many people I know when I was young and I get HIV infection. I don't want to disclose my status, but my registered hospital, I have to take drug. get treatment on that. It would be better go outside the communities, but it's also at least for severity of the symptom. Mhm. Okay. And also, we still have gap in health literacy. Even we try to promote HIV literacy through the education system, but in the annual HIV HIV knowledge survey, most of people still have unclear understanding about the HIV infections and the root of the how is transmit to each other. Mhm. So we have to continuously educate about HIV literacy. Ah, sleepy. No. Just an hour. Mhm. Here is the infographic that reflecting the social development of health related to HIV and sexual reproductive health in equality. Mhm. Okay, maybe I will bring you to explain what are the key populations in Thailand. That is the center of the problem, center of HIV program. Yeah, young adolescent. Oh, because they cannot earn the money by themselves, right? Sometimes when they want to get luxurious brand name or more money, uh some people involved in the commercial sex with the unprotected sex. They is vulnerable for unprotected sex. Mhm. And what else? Peer influence and relationship. Sometimes when they immature, they how to say practice and try to have sexual intercourse as the life experience. This is why they is vulnerable to HIV. Mhm. Mm. LGBTQ plus lesbian, gay, bisexual, transgender, and queer in Thailand. I think the situation about gay pride, have you heard about that? Gay pride is an annual festival whenever the people gen- uh, from several countries fly to Thailand and celebrate the festival during the Songkran festival. Here is they have several kind of stigma and discrimination as well because gender not conforming to their physical biological sex. Next is about the commercial sex worker. Wow. I use the AI to generate, so it's not disrupt the privacy of anybody. Mhm. Sex worker, because they has a lower education, lower education, they have no choice, and because of their uh, peer peer network, invite them to the to involve with the commercial sex. Mhm. And this job is not respect for or legal in Thailand. So the police also harassment ask for money from them. Mhm. and whenever they uh, get the get infectious HIV infections, they don't have health security, or the money is not enough to pay for the treatment. That is uh, this is the situation the sex worker experience uh, in the HIV epidemic situation. Wow. Next group. Next group is people who inject drugs. Drug using still labeled with social evil, right? People who use drug is the bad guy. They should not appear in any corner of society. This is push them and drive them to have unhygiene and cannot get a job. When they cannot get a job, they cannot earn money, and when they get illness or receive HIV from their friends during the sharing needle and syringes, they have no choice, no um, opportunity to get treatment. Mhm. Mm. Okay. The last group, migrant worker. There is an estimation in Thailand. There are almost 4 million migrant workers living in Thailand. When they come, not all of them come with a work permit, not legal migrant, illegal migrants as well. So they don't have a choice. And when they get infectious or they get ill, they less likely to get the treatment because the price is expensive compared to their daily wage. And they also have the lower education and information about HIV and sexual reproductive health. Mhm. And work and living condition is unhygiene, under 3D, dangerous, deadly, dirty, something that is drive them to get a disease, especially for TB, tuberculosis, something, TB virus. Mhm. This is some example of marginal key populations the center of HIV program that Thailand try to support and tailor the programs or health services focusing on these four group of people. Um, wait. Migrant worker, drug user, sex worker, LGBT, and young people. Okay. Okay. Can I take a break for 15 minutes? Maybe you sleep already. Ah,
Siswa, Bidon, Jandon akan take a break maybe 10 menit ya. Maybe 10 minute, Bidon.
10 minutes, 10 minutes.
Oke, 10 menit. Adik-adik juga monggo istirahat dulu. Ya, nanti setelah ini disiapkan pertanyaan. Maybe after this we can, the student will give you some question for discussion. Maybe
Ah,
like that.
okay, good. And
Okay,
then continue after
I can,
Q&A, continue
yeah.
for lecture later.
Okay, ja.
Okay,
Okay, Bidon, you may take a break.
thank you. Okay.
Are you ready, Bidan?
Yes, shall we
Okay.
continue?
We will start the Q and answer.
Okay.
Okay, please, student, you may give the question to Ajandon. You can write down in the chat room or you can directly give the question to Ajandon. Bidan, after this, my colleague will lead the discussion with
Okay.
Dion. Okay.
I also have alternative choice. Here, your student can scan and send the question. Mm.
Okay. Student, you can scan the QR code and then write down the question.
Or open your microphones and ask the question.
Yeah.
If if you are student, don't ask questions. I will ask your student question. Is that okay? Okay. Oh, what do you want to? Oh, yes, please, Fatika. Uh, speak. Open your microphone, please. You don't open microphone yet. Fatika Nadine. We can't open our mic. Farid, what wrong?
Okay, I'm sorry.
Yes, please.
Okay, good morning, Mr. Don and also Mr. Farid. Thank you for giving me the opportunities to ask you a question. My name is Fatika Nadine Hadiana, or you can just call me Nadine. Okay, maybe straight to the main question. This is the question I curious about is according to recent data from Thailand, HIV incidence has declined overall, but it remains highest among young men who have sex with other men and transgender women. So, how can public health interventions be better tailored to reach these populations while also protecting their rights and reducing stigma? That's for my questions. Thank you.
Okay. Ah, actually, the answer will appear in the later slide. But however, let me explain. Uh, in the past, MSM don't have expectations on dignity as a human for the human right, but there are many groups of MSM, especially NGO from the international donor who provide funding support, and then they can mobilize their group and gradually how say raise the campaign in the society and to fight against discrimination and stigma for how say many decades, more over 20 or 30 years, until they can get acceptance for their identity. And as you may know that annual Pride Festival is organized in Thailand and really well known for MSM from around the world who join this festival, and is gradually increase the acceptation from the society. This is a long way to fight against social stigma and discriminations. And why this population is high? Maybe they feel comfort and confidence to reveal their identity compared to the others key affected populations. It's like a mechanism to group mobilization. That means empower. They empower among themselves and empower people who empower society to understand them. And the government officer also have the neutral and positive attitude toward the identity of this group of populations because it was labeled as like a cheerful, funny people or don't danger compared to the other group of populations. Maybe that's a reason why they can accept. Is that that this I answer your question fully answer your question?
Okay, so a multi-sectoral approach involving NGOs, community mobilization, and public awareness campaigns too is essential to effectively reduce HIV incidence among these populations, right? And it took a long time, maybe.
Yes, a long time. Is like the population themselves, they have to have unity, work together, empower among them. In the past, there are small group, but when they have event to come together and show the power and make a campaign, social campaign to the society.
Okay, that's answer my question. Thank you.
Thank you, Nadine. Can I answer the question on the board? I am interested in the PMTCT. How do you motivate mother to follow this program? You. Right. I like to how say because Thailand healthcare systems is quite prominent and how say really solid on the antenatal care ANC antenatal care in every healthcare setting, even the community hospital, they also have ANC clinic and regulations and health promotions for pregnant women and women in reproductive health to go to the ANC clinic, follow up, continuously follow up for 12 weeks. So the first time when they get to ANC service, the counselor, the nurse, and the medical doctor provide the HIV counseling and testing for them to know their HIV status. And for those who get HIV from their husband, we give the choice for the mother whether she want to bearing their children or get abortion. That is a the process. And we also have the ARV antiviral treatment ART to dispense to the mother when they how say at the first few week first weeks of pregnant, and get the regimen of ARV. It can stop transmission from the virus from mother to children. This is medical advancements, and also the regulation for pregnant women to get a VCT, voluntary counseling testing, at the first time when she visit ANC clinic. That is the process. Any student can open your microphone or send the question here. I think in Indonesia still have the high fertility rate, right? What is TFR in Indonesia right now?
TFR, I think it is around 2.1, I guess, but 2.2. Yeah,
Oh,
around.
thank you. Good morning. You are lecturer, right?
Yeah. Good morning, that's all done. Okay.
Nice to meet
Uh,
you.
Nice to
Oh,
meet you, Dr.
that's great.
Okay. Yeah.
Indonesia TFR still in at the replacement rate, right? 2.1. Good. But in Thailand, right now, less than one, below replacement.
Yeah, and that's another challenge.
Yeah.
Okay. Can I ask question, Dr.
Please.
Dorn? Yeah, okay. So in your experience in Thailand, what strategies that have been most effective in reducing barriers to HIV prevention and also reproductive health services among vulnerable population, and how transferable do you think these strategies are to other Southeast Asia countries like Indonesia?
Excuse me for like what strategy and campaign that Thailand can use to reduce to respond HIV, right?
Yeah.
Okay. At the very beginning, we use fear approach that AIDS is death is not work. But right now we have how to say social campaign, like HIV is treatable. That is one thing, and medical advancement for universal health coverage that make people who get infections get the treatment, get the medicine earlier stage, and is how to say the treatment similar to chronic disease like NCD, DM. Get take the medicine every day. That can reduce the how to say reduce um the surrounding people to get doubt why that guy get take the medicine on daily basis, because the treatment similar to NCD right now. And medical advancement and social campaign, including the collaborations between community people, that mean people affected to the HIV. And also we like to thank international funding support from the UN agency that uh, can mobilize both government sector and NGO and community people to think to work together and increase sense of ownership. This problem is for of everyone. That is technical and the strategy that we used in Thailand in the past. Is this answer your question? And what is
Yeah,
the
yeah.
next question? I forgot, sorry.
Yeah, no, no, right. It's answer my question. Yeah, yeah, it's very interesting because you know, in HIV we know about triple 90.
Yes.
Okay. And in Indonesia it is very low, I guess. I don't know the exact number, but I think the first 95% of people living with HIV know their HIV status. I think it's
Yes.
not really high. Okay. So uh, for the other 295 is really low in Indonesia. Yeah. So yeah, it's really challenging how to know people with HIV and also how to treat them because it is very hidden population in Asia and also it is you know we have very big stigma about HIV. Yeah, that's our problem, I guess.
Yes, I think so. Comparing to Thailand, maybe I bring the slide. We also work on 95 cascade. And here is the country profile. The first one to know the HIV status. We have to rely on the health facility, healthcare system in the countries because in Thailand, we have many level primary, I'll say, community hospital can also get HIV tests, and the provincial hospital also special clinics for uh, marginal population also can provide HIV testing and diagnose uh, for one day result. If the system is good and in place and available free of charge, or the low price, then we can increase the percentage of people who want to get testing and know their status. Depending on healthcare system in your country as well, or special clinic get funding support from the international donor. For the second 95, for those who know their status should get virus, sorry, ARV, to get the medicine at the same day or in the fastest period. In Thailand, we still have some problem because HIV linked to the stigma and discrimination. It's quite hard for the patients to accept their health condition, to accept on their results. Then they less likely to get treatment on the same day or a short period. This is common of ordinary people. No one can make decision at the first day that they know their status. However, compared to the special clinic that provided by the key affected populations, they can make the clients feel comfort to take ARV at the same day when they get know the HIV status. And for the 95% is about ARV suppressions to control their viral load, right? Below 200. That means the cut point, the virus cannot spread to the sexual partner. Because we have universal health coverage, free of charge, then they can get medicine and take it on daily basis that can suppress their viral load. This is how to say, is require many condition. Basically, the health system is the key point. Healthcare system in the country is the key point. Can I go to
Okay.
next lady?
Yeah.
Maxine T. Sorry. Maxenita.
Maxentia,
Maxentia, sorry.
please.
Sorry. Please open your microphone.
Okay, can you hear my voice, Mr.
Yes,
Don?
yes, clearly.
Thank you so much for your opportunity. My name is Maxentia Septi Erli. I am a master graduate for health
Wow.
promotion. Okay. I live in Semarang, and near my house, there was a red light district, but it has been officially closed since 2019.
Mhm.
I remember that my lecturer said that this location make it easier for us to carry out the preventive promotion missions, especially for our job as health worker. But on the other side, in Indonesia, our culture and religion are against this because they are considered to support free sex. What is your opinion on this? Do you have any view in your country? Thank you.
Red light zone nearby your house, right? And you want to provide health promotion or health intervention in that area, right? Am I correct? Are you still here? Okay, what are the opinion towards commercial sex worker, right? In Thailand, it's not legally accepted. It's a gray area. However, when we want to make collaborations toward the health provider, we bring the health issue, the health problems on the top of discussion. And community mobilization is also the key point. However, I think because in Thailand, the religious is not how say not so strong Buddhist. We not condemn this kind of job. And I think it take time to increase the acceptance from the governments or stakeholder to accept these kind of jobs. And if the country can have the national say survey on different kind of population, like a national health behavior exam or HIV testing for let me think. IBBS. I think did you conduct that survey in your country, IBBS, right? If the result reveal that the percentage of HIV infection across the key populations that I show below this slide, if HIV infections in HIV prevalence among these key population is lower than general population, that you can use the data to convince the government officer or community people to bring about health issue to discuss for the further health promotion care and treatment. This is take time. It cannot change in the couple months or a year. In the past, we also experienced that situation. Okay, I will show you here. In the past, HIV infection rate highest among commercial sex worker, and in the past, this group of people was condemned. HIV was condemned as the sex worker disease. It take time, and right now, as I remember, the HIV prevalence among sex worker is really low. to 2 point something %. Similar to general population. It take time. Make Cynthia, am I answer your question?
Of course, I get the point. Thank you so much.
Okay.
Okay, anyone?
If not, I
Are
will
there
continue and take a break and Q&A again.
okay, yeah. Okay then.
Okay, I
So-
will continue my lecture on sharing work experience and take a break for discussion again. Okay. Here is the new paradigm of HIV/AIDS response. As I mentioned previously, we use fear approach. HIV is dead, AIDS is dead. But when the evidence show the progress, this is the current framework, Thailand framework to act to respond on HIV. RRTTPR, it stands for reach, recruit, test, treat, prevention, and retain. For the R is proactively engage vulnerable key population, like I mentioned previously, MSM, sex worker, people who use drug, migrant worker. We use their community people to reach out their network. Okay, oh sorry. Their network. And they try to bring them to the healthcare system to get health educations and encourage them through the voluntary counseling, HIV counseling VCT to provide testing. We try to encourage people to get the to know the HIV status earlier on the stage, because it can make the treatments more effectively compared to when they come to the treatment with the highest viral load, very high viral dose. And for those who want to test, want to treat both ARV and TB, we also have clinic, HIV and TB clinic at every level of health facility. But for those who get test and negative, we try to prevent them, provide another prevention. We introduce PrEP. I will explain later what is PrEP stand for. It's a medicine that prevent you from export when you export to HIV the virus. And finally, we try to retain both who get HIV infection and both HIV positive and HIV negative people in the healthcare system for the long term and routine checkup. And also on the medical adherence for those who take ARV from the treatment. This is this continuum of care originate from Thailand, and thanks to the international funding support and collaborations from government and NGO and the community people themselves to provide and make this technical framework. Here is the foundations why RRTTPR happen. I will send you the slide later. Okay, in terms of PrEP, it stands for pre-exposure prophylaxis. That means a medicine you take before you expose to the virus regimen. You have to take it at least 2 hours, up to 24 hours, 1 day or 2 days before you get a sexual you get unprotected sexual intercourse. These can help and support the couple who when a couple want to have children, right? They cannot use condom. This is the way to prevent to get virus. And for some people who don't want to use condom, they have to take PrEP, like how to say long-term medication, similar to long-term medications. However, some people think that PrEP can increase the STI or not, because PrEP can prevent only HIV virus. It cannot prevent you from the sexually transmitted infection, right? This is a common assumption. Even me, I also doubt. Oh, in the past we promote 100% condom. It can protect both how to say three unintended outcome, like HIV infections, STI infection, and unwanted pregnancy, right? But when PrEP is introduced during the highest stable of STI incident rate. Is not the PrEP is not right. The STI rate in Thailand increased, is already increased at the peak highest rate of the curve, and then PrEP is come to save them from the HIV prevalence. This is before we introduce PrEPs, we conduct study about 5 years in the 3 phases. I will give you the slide later. Maybe I can skip this presentation. Is a process and the phase of clinical trial and clinical study. And here is the some evidence. It can reduce syphilis. Oh, sorry. Reduce the syphilis from 7 to 3% at one period of the study. Okay. This how is the routine screenings? Screening expose a high baseline burden among vulnerable cohort. There is a strong evidence point out that youth and transgender women can reduce sorry, baseline incident reach. Sorry. I think it means that PrEP is suitable to prevent the prevalence among these target population for the youth and transgender women. That's why we target these population, because they recently like newborn. I mean Gen Z, right? They may not familiar with the HIV situation compared to people in the middle adult or old age. They're not concerned about condom use. That's why we introduce PrEP to these populations. Okay, here is the current campaign of Thailand. Overcoming fear campaign from AIDS equal to death, to show the picture of people who get infection nearly dead. We promote you equal you to empower people. Okay, this is from clinical trial and clinical study also. First one is undetectable equal to untransmittable. That means undetectable. It doesn't mean zero viral load, but for those HIV patients, HIV people who get ARV suppress their viral loads below 50 copy per ml. This is cannot transmit or untransmitted to their sexual partner, to their husband, or to their wife. They can have sexual intercourse without condom. If they want to increase their pleasure or have get pregnant or child get pregnant. Or in case in some couple, they hesitate or they afraid to reveal their HIV status, and I think Muslim people maybe reject condom use, right? Reject condom use. This is suitable for promote in the specific group, specific people who cannot use condom among their couple. This is the study. Like if those who still have viral load, it can transmit to their couple, but if those who detect lower 50 copies of viral dose, then zero risk zone, they can take they can have sexual intercourse with their couple after they get PrEP. Here is the comparison between people who taking PrEP medicine, and we promote this campaign U equal to U, but is can protect only HIV, but it cannot protect you from STI and cannot protect from pregnant. So we promote dual protection. Use condom also in case of you can negotiate with your couple, your partner. Okay, here is from that clinical study. Now we promote U equal U framework for the national standard, national regimen, because before we use this campaign, we have study from the Western country, and we conduct it in Thailand, and the result also confirm. Then we endorse the policy to provide the PrEP under the U equal U framework, and can provide to the community-led healthcare setting. I will explain you later. Okay, this is I think I already explained, right? Before one person get PrEP, they have to testing ART access first. If the result test that still have higher 50 ml 50 copy per ml, they cannot get PrEP. They have to take ARV to suppress their viral load first. Okay. Here, this is the another new innovation in Thailand country. We call key population-led health services. This is bridging the gap between marginal community and national health system. Okay, here on the left cycle, this is the conservative healthcare facility that legit infrastructure like a passive care and treatment. And clinical authority, that means only health provider can make decisions to provide healthcare service. But this is the new one, key population-led health service run by the community-based organizations. At the ground level is located in the community where the key populations are residing or at the convenience place is sorry, I don't have some picture, some photo to show you. However, the people from these KPLHS community-based clinic, they have to pass get training from the Ministry of Public Health in the several course and have to get take exam as a health provider to like similar to license to provide some specific health how say health service like HIV counseling testing to draw the blood test and also can dispense provide PrEP pre-exposure prophylaxis medicine. The core component of KPLSS, that's community people-led health service. I may use the words community clinic for easier, but please understand that that means KPLHS. Okay, it's like since this clinic run by a non-government organization or NGO or community people, they know where is the hotspot area of these people gather together. Then that is the location to set up the clinic. And the services provided by their member, their people, so they can create the friendly atmosphere and some clinic open after office hour. That is can suitable for working people compared to the hospital operate in the working hours 8:30 to 4:30. Some people work in the private sector cannot go to the clinic. And also some community clinic can provide send the deliver condom HIV cell test kits and also needle syringes for people who use that. Okay, deliver to the parcel and get trained to deliver the healthcare service. This is comparison between traditional public health and KPLHS model. Accessibility, I think I already mentioned, like, for this community clinic directly located in hotspot, easy to go, easy to travel, availability that there are health service that serve their need. For the community clinic run by LGBT, some clinic provide hormone, female hormone, compared to people who use drug. Some clinic can provide needle and syringes to reduce sharing needle among their group, and can also provide a PrEP for the quality because traditional public health or hospital, the quality may not meet the standard for specific group because the main responsibility to focus on general people, right? General other chronic disease. But for the community model, they have to train specific train and get certificate to provide the service specifically to key population. And acceptability that some clinic cannot provide all cascades because number of people, number of health provider not enough to serve underserve the patients because this is the setting on the general in the government hospital. But here we mobilize committee people, and there are plenty of staff to serve and understand the key population needs, like understand and empathy what they need. Okay, here is the ecosystem of the key population-led health service, or KPLSS, that more than the clinical treatment, health management or case management. For those who get HIV first detect, they have referral system, refer that case to the government hospital, and in some case they can send the ARV drug to the health community community clinic to dispense ARV in some clinics. Referral treatment provide PrEP, STI counseling, and some can get treatment or diagnosed, and also can empower key populations, key affected population. Okay. The concept is that these KPLHS can supplement, not just only support, supplement and become an alternative choice for to support government hospital or government clinic, because they cannot operate outside the working hours and cannot have plenty of health provider to support and provide technical I'll say technical term, or understand the technical term, or understand the key populations, all of key populations. Here is the more like the loop of providing loop of setting up and service. This community clinic can building trust among specific group and access and outreach, because the NGO also have outreach outreach program to reach out the hidden population and recruit them to testing, HIV counseling testing, and refer them to get ARV at the hospital. Okay, then it can increase the retention rate to keep these key affected populations in the healthcare system, not drop out during the care and treatment. Okay, maybe okay. Let me explain 2 more slides, and then I will open floor for the discussions. Okay. Before the community clinic can happen, we have some institutions to work in the technical assistant to get training and guarantee the existing of care of the health of the community clinic. And then when the standard pass the technical team, these model advocate to ensure that Ministry of Public Health legally approved for this clinic to provide HIV services. And since the clinics have to follow the national standards and quality, they have to get approved from the Center of Disease Control, Ministry of Public Health. The health worker, the worker in the in the clinic have to get examinations, get trained and get examination from the Ministry of Public Health also. And in the future, these clinic can claim the financial support from the National Health Security Scheme that use the our tax to operate the clinic. This is the concept of setting up the KPLHS, key population health service, to give the community the tools and they will help finish the job. Key population-led health service for ending AIDS in Thailand. Like these community empowerment, turn the patients or the passive receiver to be the active provider, and a kind of decentralized healthcare services to the local communities, because government hospital don't have enough health provider compared to the number of patients. Okay, I take a break on this, and everyone can ask the question.
Okay, thank you, Dr. Dorn. Just to remind you that maybe we will finish this lecture at 11:30.
Oh,
Okay, yeah. So it's about 20 minutes from now. Okay, yeah, because we have we need to doing Jumat prayer. Okay, no problem. Okay, then can I translate it for the students? Okay. Yeah. Okay, I will translate for the students about your presentation. Okay. Ya, jadi teman-teman tadi Dr. Don menjelaskan ya
oh.
terkait dengan apa namanya beberapa hal ya terkait dengan program yang ada di Thailand ya. Ada RRTTPR ya. Oke, intinya adalah HIV ini harus di reach dulu, kemudian ya nanti sampai ke testing sampai ke diobati gitu ya, dia begitu. Jadi penemuan itu sangat penting ya, intinya begitu. Nah, terus tadi beliau juga memberikan gambaran tentang KPHLI, saya lupa itu dia. Oke, intinya itu adalah yang berbasis komunitas ya. Jadi kalau di kita kan ada beberapa komunitas yang terkait dengan HIV ya. Misalnya ada komunitas khusus LSL ya, MSM ya, lelaki seks laki atau men seks with men. Terus ada yang lain lagi gitu ya. Nah, di sana di Thailand itu mereka sangat terlibat aktif ya. Tadi dijelasin ya bedanya antara tradisional apa namanya fasilitas bis tradisional tadi ya. Jadi intinya bahwa penderita harus ke puskesmas atau ke rumah sakit gitu ya buat dapat obat. Nah, kemudian ada juga yang via community. Nah, KPLH itu adalah di tengah-tengahnya. Jadi penderita itu bisa bukan menderita, pasien ya, pasien HIV itu bisa mendapatkan obatnya di KPLHS ya, sorry. Bisa mendapatkan obatnya dari komunitas. Nah, jadi itu di Thailand ya. Tapi kalau di Indonesia memang belum ada seperti itu ya. Atau obatnya harus dari rumah sakit ya. Dan banyak sekali hal yang dilakukan di KPLHS ini ya. Intinya mereka bisa sangat kuat di sana, makanya eh, penemuan dan juga pengobatan di sana sangat tinggi, sangat bagus ya, berbeda dengan kita ya. Dia seperti itu. Oke. Nah, silakan bagi teman-teman kalau ada pertanyaan. Or Dr. Don, do you want to continue your material or we can open the question?
Sorry, because you have to go to play, right? I have to
Yeah.
finish at 11:30, right? Let me
Okay.
go on a couple slides to sum up. And
Okay. Yeah. Thank you.
this presentation I will send to Dr. Farid to distribute to your student. Okay, this is a country experience and long journey that Thailand respond to HIV. We create many innovations, many technical support or framework to tackle the HIV situations. The uh, key success is collaborations among every stakeholder for the healthcare provider or government, let's say governments, community people, because we don't treat them as the patients. We empower them to mobilize their community and set up the clinic, right? And the funding support also is important. And I try to link the HIV response to the public health care preventions continuums. That means we can apply the public health, right? You have studied these concepts already: primary prevention, secondary prevention, and tertiary prevention. This is you have to combine it. It cannot solely separate to provide a service alone, but we have to linkage combinations of all of these three components for the HIV care and prevention, care, and treatment. I think you can go. You can read my slide in detail. Okay. What is okay. This the core concept. As you are student in public health, right? We have to emphasize on prevention, health education, and prevention first. Health promotion to get healthy, empowerment people, and we also need the evidence-based monitoring, evidence or research that we can have a strong evidence to support, to convince the government or the donor to get support on activity or the funding, right? And if possible, we push the policy, our study or our result for the national strategy, such as I mentioned you previously about the pre-export prophylaxis, and also committee-led people committee clinic, right? Because treating one illness, one patient is require more health provider, but we have to emphasize and focus to prevention is put more effort on prevention than looking and hope for treatment, because right now we didn't have medicine to treat cannot cure the patients back to the normal state. We can just only suppress their virus, not let them have severity symptom for the AIDS patients, just support them to living with HIV virus. Okay, sorry, I don't have time. Here is integration about HIV, family planning, and STI. If possible, you have to provide synergic integrating these care and service together. We cannot provide healthcare on each component alone, because it has some interconnected disease, like cross-cutting issue for, right? Sorry. Okay, this is conclusions of my sharing experience. We have to redefining public health for vulnerable populations. Treating them if we use the clinic base or treat them just only in the clinic, we will fail to reach the hidden population or vulnerable patients. and only provide the medicine, even medicine advancements, more advancements, but we cannot just focus on medication only. We have to determine social determinant of health, right? For the right or reduce stigma and social support. And Thailand countries that progress on universal health coverage, that is how to say backbone to support our HIV program, because UHC universal health coverage that every Thai citizen who was born and have Thai national citizen card can get free of charge for every step of HIV HIV care prevention care treatment. And also we have the community-led KPLHS to supplement and to share the workload of government hospital to taking care these group of people who living with HIV, because nowadays in Thailand we have the problem on the NCD disease and hypertension, DM. So this is we have to redefining public health for vulnerable populations to tackle HIV situation. I hope that my sharing experience and my slide will be how say will or may support you get to support and give you some idea for the further HIV program and including the public health care public health study in your faculty. Okay, this is some how to say some document to read for the further study, or you can send me question to Dr. Farid if you want to do so. Thank you for joining with join my session. Okay, that is all.
Okay. Thank you, Dr. Don, for your material. Okay. Anyone, do you want to ask question for Dr. Don? Anyone? Ya, tadi mungkin ada yang belum mengerti ya, PrEP ya. PrEP itu apa sih sebenarnya? Jadi sekaligus saya jelas nih. Apa namanya, kalau kita tahunya mungkin prevention untuk HIV itu apa sih, yang kita tahu mungkin kondom gitu ya. Nah, sebenarnya ada prevention lagi yang lainnya, yaitu bentuknya obat ya teman-teman. Obatnya namanya PrEP ya. Tadi udah jelasin singkatannya. Jadi PrEP ini dipakai untuk mereka yang negatif ya, negatif HIV, yang mungkin punya pasangan yang positif HIV. Oke. Jadi ini diminum oleh yang mereka yang negatif HIV gitu ya teman-teman ya. Jadi ini sebagai mencegah orang yang negatif ini biar tetap negatif. Jadi mereka misalnya keluarga gitu ya, misalnya suaminya positif, istrinya negatif gitu ya. Nah, istrinya yang meminum obat ini. Jadi tetap mereka eh, bisa melakukan hubungan ya tanpa khawatir ya untuk tertular. Seperti itu intinya. Oke, silakan teman-teman. Ada pertanyaan untuk Dr. Don? Ada, boleh di chat, boleh langsung bertanya, silakan. Oke. Okay, so that I think our student doesn't have any question, but maybe I want to share more information about Indonesia. So in 2024, we got the project from UNH to conduct DSD in Indonesia. DSD is differentiated service. Sorry, I don't remember. Okay, DSD. Okay. So it's it is access the DHPS differentiated test for HIV, differentiated ART, and also for AHD. Okay, and from that assessment, we know that for triple 95 in Indonesia, we have the first 90 is 77%, only 77%. The second one is 45%, and this third about 46. So it's very low. Okay, very low. So it's very higher. And from that assessment, we know that maybe you call it community clinic.
Yes.
Maybe it's not really suitable for Indonesia, because in Indonesia we the community cannot give the clinical services. Okay, so if they want to get the medicine like PrEP or anything, they need to go to the clinic, or the special clinic, or just clinic. Okay, but the community can reach and can help the other member of community to get the medicine from the clinic, or maybe from the DHO. So that's what happened in Indonesia. I think we are far away from Thailand. Thailand's very good for
Thank you.
HIV prevention and also medicine. Okay, yeah, that's what I can share for you about the Indonesian condition. Okay.
Okay, I give my support for you, and if you want to learn more, maybe we can have another session specific to HIV program in your faculty. Let discuss. I think maybe we have another opportunity to talk.
Yeah, of course. Yeah, okay.
Yes.
Sorry. Teman-teman ada pertanyaan untuk Dr. Don, silahkan. Boleh chat, boleh langsung bertanya. Ada? Belum ditutup? Belum? Not yet. Okay. So, okay. Sumaya, please, Sumaya.
Okay, your last chance.
Okay, good afternoon. For
Not
the
really.
group presentation.
Yes.
I am actually not very clear about the KPLHS program. From what I understood, it's like you are saying it's not covered by the government or the NGO, right?
Run
So-
by the NGO, yes.
It's like from the community. So how do you like source for the funding to pay the officials, the workers in that health system, if the government is not the one that is taking care of it and it's not covered by the NGO?
Okay.
And then also, how do you source the drugs and the medications to provide the service? Thank
Okay.
you very much.
Okay, it's a wrong history because most of the community clinic run by NGO at the beginning they the provide outreach work. That means people who reach out their specific group in the community, and when they refer the case to the hospital run by government, increasing number of cases, and then there is a international organization to support these how say empower the local people, the community people to have a skill on HIV service, but this is this community clinics is not fully operate same as the clinic in the hospital. Mainly we can provide VCT, voluntary counseling testing, and blood test for HIV and syphilis, and have can provide PrEP, the prevention medicine, and also get the medicine from the hospital clinic to dispense to the patients who feel comfort to come to the clinic instead of go to the hospital. It's a long history, and we have to the committee people or the NGO have to work closely with the government clinics to get how to say, to prove themselves that they can support the workload of health provider in the healthcare setting run by government. This is the process why KPLSS can establish and exist at the present. Okay, am I clear? Is that
Yes,
clear?
thank you very much.
Yeah, everything is take time because now is 44 years, almost 50 years that Thailand have to respond to HIV. It take time, and we can learn from the other success country. As I mentioned, key point is we have to have strong government authority to take concern, and community empowerment. People from the community, both general people or key population people, have to gather together for mobilize and work for their community. And next is we need technical support from the success country or the Western country, also UN agency. This is a key success of Thailand, how we respond the HIV situations at the very beginning until the present. Okay.
Okay. I want to ask question for Dr. Don.
Yes.
Anyone? Please? No? If there is no question from the students, maybe could you please give us the closing statement, I guess, from Dr. John, please? Do you have closing statement for this lecture?
Assessment.
No, closing statement. Sorry.
Or
Okay. Do you have, Dr. Don? Do you want to give our student the last statement?
last statement. Okay. Okay. As you study in the public health, right? Public health, faculty of public health, and Indonesia, the countries has more than 1,000 island, right? More than 1,000 island. So you may
Yeah.
have unique and specific health issue depending on geographical area. So I support, and I no, public health, right? Even you are not study as a medical doctor or nurse, but public health is also important because we can prevent many people not get ill from any kind of disease or slow delay of disease occur. Your job, your positions also important. Don't compare you with your friends who study in medical doctor or nurse or POSI. You are the frontliner. Please proud of yourself that you choose to study in this area. Proud to be yourself, not compare to the doctor or the nurse, because they have to work in shift for the whole day or whole night, and uh, premature death from the workload. Uh, Please enjoy your study life in this area, and to be proud of yourself to prevent many people from getting ill or get disease. That is my last words.
Okay, thank you so much for Dr. Dunn. Yeah. I love the word frontliner. We are frontliner to prevent the disease for everyone. Okay. Thank you, Dr. Don, and thank you for all of the students. And please don't forget to fill the presency link that I have already shared to you. Okay, thank you so much, Dr. Don.
Thank you,
Thank you
everyone.
all.
Enjoy your lunch.
Okay, bye-bye. Thank you all.
Okay.
Jangan lupa presensi ya teman-teman ya. Silahkan presensinya di